Hello, I'm Ernesto Schiffrin, and I'm going to be talking about the newer agents to treat hypertension. Let me share my screen. So I'm going to be talking about novel antihypertensive agents, of which there is a large number currently. I'll start with my disclosures. So what is new in treatment of hypertension? Here we have the list of agents, and I'm starting with Entresto, the angiotensin receptor blocker valsartan with the neprilysin inhibitor sacubitril, which is approved in some countries for hypertension and heart failure. Then there are the endothelin antagonists, aldosterone synthase inhibitors, the nonsteroidal mineralocorticoid receptor antagonists. I won't be referring to them. They are not very powerful antihypertensives. These include finerenone, isaxarenone, ocedurenone, aparinone. All of these have an interest in diabetic kidney disease, since they have been demonstrated to exert significant protective effect and reduce progression of chronic kidney disease in diabetes. Then there's the angiotensin synthesis inhibitors, such as silebesiran, or the antisense Ionis, AGT, LRX under investigation. Atrial natriuretic peptide, I won't refer to this. There's only one open label, single dose, small trial for this one. And firibastat, which is an aminopeptidase A inhibitor that lowered blood pressure in a multicenter open label phase 2b trial. So let's just mention briefly, this is our study when we put together valsartan together with sacubitril and demonstrated powerful blood pressure lowering effects in spontaneously hypertensive rats. This was associated with potent vascular and cardiac protection. And based on this, Novartis developed the agent for heart failure, and the rest is history. However, in some countries, the association of valsartan and sacubitril, called Entresto, is used in the treatment of hypertension, especially in East Asia. Now, what about endothelin? I mentioned the development of endothelin antagonists, and we have been involved in endothelin research from the very beginning after the discovery of endothelin by Masashi Yanagisawa in 1988. We demonstrated for the first time that endothelin was involved in experimental models of hypertension, and in humans with difficult to control or resistant hypertension, we were able to demonstrate overexpression of endothelin mRNA in the endothelium of these blood vessels obtained from gluteal subcutaneous tissue. And we advocated for many years for the use of endothelin antagonists in hypertension, particularly in difficult to control hypertension. This shows the vascular endothelin system with ETA and ETB receptors in smooth muscle that endothelin acts upon to induce contraction, growth, and inflammation, and ETB receptors in endothelial cells on which endothelin generated in the endothelium acts in a paracrine fashion or autocrine fashion to induce release of nitric oxide and prostacyclin and induce vasodilatation. So is endothelin a vasodilator or a vasoconstrictor? Apparently, from a number of genetic studies and knockouts and different mutants of endothelin receptors, in normal conditions, endothelin may be a vasodilator, but in hypertension, it acts as a vasoconstrictor. So aprocitentan is a dual ETA-ETB receptor antagonist that, through blockade of ETA and ETB receptors on smooth muscle cells, will produce vasodilatation. At the same time, it will block endothelial ETB receptors and result in reduced clearance of plasma endothelin that may increase, and is a demonstration of the dual ETA-ETB receptor antagonism. So this is a paper in The Lancet, published 2 years ago, demonstrating that aprocitentan is effective in the precision trial in resistant hypertension, a phase 3 trial, which was a multicenter blinded randomized parallel group study. This shows the design and methodology of the study. Patients with resistant hypertension were screened on a standardized background therapy and then double-blind randomized to aprocitentan 25 milligrams, placebo, or 12.5 milligrams, then single-blindedly randomized or transferred to aprocitentan 25 milligrams for 32 weeks, followed by a double-blind withdrawal of 12 weeks. The withdrawal part was agreed with the FDA, and you will see that it's an important part of this study, and there was a safety follow-up of 30 days. Primary endpoints were the change from baseline to week 4 in mean trough sitting blood, systolic blood pressure. Key secondary endpoints was a change from withdrawal baseline week 36 to week 40, the part 3 in the mean trough sitting office blood, systolic blood pressure, and other secondary endpoints were changes in 24-hour ambulatory blood pressure at week 4 and week 40. This shows the precision study population, age around 61 years, 59% were male, 84% were white, most were overweight. There was about a quarter of the patients in the placebo or in the aprocitentan 12.5 or 25 milligram group that had a eGFR between 15 and 60 milliliters, indicating chronic kidney disease. And you can see that blood pressures on AOBP unattended were around 153/88, and ambulatory blood pressure was 138/84. History of heart failure was present in 20%, and 54% had a history of diabetes. This shows the double-blind period. You can see the very potent placebo effect with reduction in the blue line of blood pressure, but greater reduction with aprocitentan, similar with 25 and 12.5 milligrams. The single-blind period during which everybody stabilized at the same level, and finally the double-blind withdrawal, where you see the placebo in blue. That's similar to the blood pressure at the end of the double-blind part 1 period, indicating that actually the lowering of blood pressure was because patients had been screened and found to have higher blood pressures than their actual usual blood pressures, which allowed greater numbers to be screened into this study of resistant hypertension. Ambulatory blood pressure shows the difference between placebo in blue and 12.5 and 25 milligrams of aprocitentan in yellow and red. And you can see the greater reduction of blood pressure, about 2 millimeters of mercury, ambulatory blood pressure with systolic blood pressure with a placebo, a 6 millimeter mercury or up to 8 millimeters of mercury systolic with 12.5, and 8 to 10 millimeters of mercury So a difference of about 8 millimeters of mercury between a placebo and the higher dose of aprocitentan. And on the withdrawal period, there is a rise of blood pressure with a placebo, but a persistent lowering of blood pressure with aprocitentan 25 milligrams. Here you can see that selected subgroups had similar results. And interestingly, when renal function was reduced, the effects of aprocitentan were enhanced. So this is important because this means that this drug can be considered as a preferential drug for patients with chronic kidney disease. And interestingly, in contrast to mineralocorticoid receptor antagonists, it will not raise serum potassium. The change in albuminuria over time in the overall population is clear with the 2 doses of aprocitentan and none with the placebo, persistent through the single-blind period, and with a significant increase in the double-blind withdrawal, but a persistent beneficial effect with aprocitentan, but demonstrating that the albuminuria returns to the basal levels when you interrupt the administration of aprocitentan in the withdrawal period, suggesting clearly that the effects seen on albuminuria are aprocitentan dependent. There were some treatment emergent adverse effects, mainly some edema or perhaps fluid retention that could be controlled with additional diuretic used in some of these patients, as you can see here, in the double-blind and the single-blind periods that disappeared in the double-blind withdrawal. In conclusion, aprocitentan lowered both standardized automated office and 24-hour ambulatory blood pressure compared to placebo after 4 weeks. The blood pressure lowering effect was maintained over 48 weeks. Edema and fluid retention were the most common adverse effects reported with aprocitentan in the first 4 weeks and were clinically manageable with the addition or uptitration of a diuretic therapy. And dual ET antagonism with aprocitentan may represent a new alternative pharmacological approach to treat resistant hypertension, maybe combination with a diuretic or even an SGLT2 that is being tried in some trials of endothelin antagonists to antagonize the edema or fluid retention may become a possibility in the future. So let's move on to aldosterone synthase inhibitors. We know that aldosterone plays an important role in blood pressure elevation, that primary aldosteronism is frequent in resistant hypertension and should be looked for, and patients screen for it if they have true resistant hypertension. But aldosterone plays also a role and in difficult to control or even type 2, stage 2 primary hypertension. Here you can see the aldo synthase production that acts on the mineralocorticoid receptor to produce genomic effects, but also on non-genomic effects through GPR30, a membrane receptor for estrogens and aldosterone. And so mineralocorticoid receptor antagonists only act on the cytosolic mineralocorticoid receptor, affecting the genomic effects, but do not affect the non-genomic effects of aldosterone. So this suggests that aldo synthase inhibition may be preferable to mineralocorticoid receptor antagonism and may be superior. Importantly, CYP11B2 aldo synthase is almost identical to CYP11B1, which is the 11-beta hydroxylase involved in the zona fasciculata in the synthesis of cortisol. So it is important that we do not inhibit cortisol and induce adrenal insufficiency when we use an aldose synthase inhibitor. And indeed, a few agents have been developed that are selective for aldose synthase and do not affect CYP11B1. So here's the phase 2 trial of baxdrostat, an aldose synthase inhibitor for treatment-resistant hypertension, published in the New England Journal of Medicine. Here you can see that of 779 patients assessed, 273 underwent randomization, and about 69 were included in each of the groups that were assessed for safety and efficacy, and in the different groups studied. This shows the demographics. Patients were about 63 years old. About half were older than 65. About 60% or between 50 and 60% were male. Most, 75% approximately, were white. They all had slightly elevated body mass index in the overweight to obese category, and their seated blood pressure was around 148/88, and estimated glomerular filtration rate about 85 milliliters. About 26 to 28% were diabetic, and essentially that is it. This shows baxdrostat effects, where increasing doses of baxdrostat in each of these groups, placebo, 0.5, 1, and 2 milligrams of baxdrostat, reduced blood pressure by from baseline by between 9, 12, 17, and 20 millimeters of mercury. So the maximum dose, 2 milligrams, reduced about 10 to 11 millimeters of mercury systolic blood pressure relative to placebo. And about 5 millimeters of mercury, the diastolic blood pressure, and these changes over time are shown in the lower panels. Urinary and plasma aldosterone and plasma cortisol are shown here, with urinary aldosterone reduced significantly by 0.5, 1, and 2 milligrams of baxdrostat. Changes in aldosterone plasma levels as well. Plasma renin activity rose more with higher doses of baxdrostat, but cortisol was typically unaffected, or if anything, rose slightly. So baxdrostat does not interfere with CYP11B1 or cortisol synthesis. The conclusion was that 2 milligrams of baxdrostat significantly and substantially reduced systolic and diastolic blood pressure in treatment-resistant hypertension. Aldosterone levels were reduced. Plasma renin was increased without reducing cortisol. It demonstrated a favorable safety profile and was well tolerated, and has the potential to treat disorders associated with aldosterone excess, including hypertension and primary hyperaldosteronism, and for the reasons I have shown at the beginning, may be superior to mineralocorticoid receptor antagonism. Other aldosterone synthase inhibitors are in development. Lorundrostat, which has been shown to lower blood pressure compared to placebo, and dexfadrostat, which as well is effective in lowering aldosterone, but does not affect cortisol. So let's move on to reducing angiotensinogen. Angiotensinogen is the origin of the renin-angiotensin system, acted upon by renin to produce angiotensin 1, which is then transformed by either pulmonary or tissue ACE into angiotensin 2, the final mediator of the angiotensin system. And this can be blocked at the level of synthesis of angiotensinogen in the liver by either antisense oligonucleotides or small interfering RNA. And without going into too much detail, let's move on to this RNA interference study appeared in the New England Journal of Medicine with cibaliceren that demonstrated dose-dependent decreases in serum angiotensinogen and 24-hour ambulatory blood pressure sustained for up to 24 weeks with a single subcutaneous dose of 200 milligrams with very mild injection site reactions as a side effect. We know from studies of the Paris and Utah group that levels of angiotensinogen are accompanied by levels of blood pressure. So higher angiotensinogen, higher blood pressure, lower angiotensinogen, lower blood pressure. And this study demonstrates that indeed lowering angiotensinogen will lower blood pressure. And this is the mechanism whereby silencing angiotensinogen works. Without going into too much details, this shows the process whereby the effects of siRNA will affect the degradation of angiotensinogen mRNA, leading to reduced angiotensinogen production in the liver. Here you have the demographics of the study of cibaliceren. Again, patients of about 50 years of age, about 50 to 60% or more were male. It's a small study, mostly white, but some Black and Asian patients with blood pressures of about 140 over 85 to 90. And body mass index at the upper level of overweight. Here you can see serum angiotensinogen reduced by increasing doses of cibaliceren, with changes in systolic blood pressure, which are greater with the higher doses of cibaliceren. After single doses of this agent at week 6, week 8, week 12, and week 24, persistent lowering of blood pressure with these doses of the agent. Very few adverse side effects, mostly at the injection site with some irritation. This has been followed by the KARDIA-1 randomized clinical trial in JAMA, published earlier this year, which I wrote the editorial for, showing that RNA, small interference RNA injection every 6 months improves blood pressure in patients with hypertension and could improve adherence. And I think this is an extraordinary development which might allow administering the antihypertensive at clinic visits of patients every 6 months, maintaining lowering of blood pressure for 6 months between visits, and certainly improving adherence to treatment. Finally, the last drug I want to mention very briefly is firebestat, which acts by reducing generation of angiotensin 3 from angiotensin 2 by inhibiting aminopeptidase A. And in a study done on hypertensive patients, it was effective. However, in the study using automated office systolic blood pressure in resistant hypertension, this was presented by George Bacris, by the late George Bacris, at the American Heart Association resistant hypertension scientific science meeting of the American Heart Association, November 2022, there was no difference, and the development of this drug has been stopped. So in conclusion, after more than 20 years without new antihypertensives, we include Entresto, which has not been commercialized for hypertension except in few countries. Now we have novel mechanisms and potential targets, as well as a plethora of new agents and devices. I have not talked about renal denervation or other devices, but in development or already approved that show promise to lower blood pressure and improve adherence to treatment, lowering cardiovascular risk, generating hope that we can improve outcomes in hypertension, the #1 cause of burden of disease and mortality worldwide. And with this, I will stop here.